Hello and welcome to today's Better Care Playbook webinar, made possible through the 7 Foundation Collaborative on using patient segmentation and data on health-related social needs to identify people with complex needs. Before we get started, I'd like to go over a few logistics. To eliminate background noise, audio lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you take a moment to do this. I will now turn the webinar over to Carla Silverman, Associate Director at the Center for Healthcare Strategies.
Thank you so much, Travis, and welcome everyone to today's webinar. I'm Carla Silverman, Associate Director for Complex Care Delivery at the Center for Healthcare Strategies. Before I introduce our panelists, I wanted to share some information on the playbook and how it can be a resource for audience members, and also walk through some quick background on the topic of patient segmentation frameworks and how they might be helpful for those of you working with people and populations with complex health and social needs. The Better Care Playbook is an online resource center for evidence-based and promising practices for people with complex health and social needs. It provides summaries of new journal articles and reports on topics such as complex care interventions, health-related social needs, and population identification and segmentation. Playbook is a place to learn about first-person perspectives through case studies and webinars that highlight implementation experiences. The playbook also summarizes and links to implementation tools to help stakeholders translate evidence and research into action. During today's webinar, we'll be drawing on some of the resources on the playbook, and we encourage you to go to the playbook for more information and to submit resources for playbook inclusion based on your own work. Next slide, please. The playbook is coordinated by Center for Healthcare Strategies through support from 7 leading national healthcare foundations: Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. You can find the playbook at bettercareplaybook.org, and we encourage you to check it out and search for the topics that are most important to you and your work. Next slide, please. Today, we'll be hearing a presentation from Dr. Jose Figueroa on using segmentation frameworks to identify patients with complex needs. Then we'll hear 2 presentations from managed care organizations, one from Luis Cabanilla from Point 32 Health, the other from Dr. Andrew Renda from Humana. And then finally, we'll have a moderated Q&A, and we encourage you to put your questions in the chat. Put your questions in the Q&A at the bottom of the screen, and we'll be having a discussion after the presentations. Next slide, please. So I want to introduce our speakers today. Dr. Jose Figueroa is Assistant Professor of Health Policy and Management at Harvard T.H. Chan School of Public Health and Assistant Professor of Medicine at Harvard Medical School. Luis Cabanilla is Director of Clinical Analytics at Point 32 Health. And Dr. Andrew Renda is Vice President, Bold Goal and Population Health Strategy at Humana. Next slide, please. So I'd like to give you a high-level overview of what you'll be hearing about in today's presentations. Individuals with complex health and social needs are a heterogeneous population. Grouping them together by those who have the highest cost and/or utilization may allow you to know where to focus your efforts, but it won't really tell you what interventions or care are needed. A one-size-fits-all approach to clinical care or social services won't work for everyone because this group of patients has a diverse range of clinical diagnoses. Segmentation frameworks combine analytics with clinical insights to help health systems and payers identify groups of individuals with shared characteristics. Once specific groups are identified, Interventions and care can be tailored to the specific needs of each population segment. Just a note that on today's webinar, you'll hear the term high need, high cost populations. And by this, we mean groups of patients who have complex health and or social needs. Now I'd like to turn it over to Dr. Jose Figueroa to share his work on segmentation frameworks.
Hi, sorry for the delay there, but thank you so much for inviting me to today's virtual webinar. It is a pleasure to be here. And as noted, the goal of my talk is to give insights into the use of segmentation frameworks into real clinical practice. And the first thing I'll start off by saying is something a lot of people on this call know is why should we focus on high need, high cost patients? And that's because, as many of you know, costs are highly concentrated among a small group of individuals. If you look across the United States, the top 1% of patients who are the most costliest patients actually account for 23% of total US healthcare spending. The top 5% account for 50% of total healthcare spending, and the top 10% account for 2 out of every $3. And the bottom 50% actually only accounts for 3% of total dollars. So there's a lot of interest in trying to understand who these people are, why they're high cost, what are potential strategies and interventions that we can do in order to sort of hopefully improve the quality of care, improve their well-being, and then ideally also reduce or control rising healthcare costs. And so that's the whole point of, I think, using segmentation frameworks as a strategy. And the key is that it has to be a segmentation framework that allows you to take action. It cannot just be something that is a descriptive framework. It has to inform what strategy your organization, your case managers, your clinical social workers, what can we do based on what the information is giving us. And so the first thing that segmentation frameworks can do is, again, help identify patients who will become high need, high cost. It can help you determine which programs and interventions may work for specific patient populations. And then importantly, it can try to help you understand whether you have high performers versus low performers within your health system, ACO health plan. And it really depends on what perspective you are taking when utilizing segmentation frameworks. And so I'll walk you through some historical context. A few years ago, there was an effort at the National Academy of Medicine funded by one of the foundations, the Peterson Center on Healthcare, that got together a bunch of people to try to figure out who are and start coming up with certain high need, high cost frameworks. And from this report, it was a series of 3 workshops across 2 years. There was a huge undertaking to try to understand who are the types of people we should be focusing on, that we should build frameworks around. And there was a few phenotypes or dominant types of patterns that I guess dominated when you looked at the data. These are the things that matter in terms of determining who is going to be a future high cost person with a lot of need. People who are frail, people with serious mental illness, people with complex multimorbidity, people with major disability, and people who are socially vulnerable. And based on these phenotypes and based on a lot of data analytics across multiple groups, there was, so before I'll just say, this is the kind of information that was used in the developing on the frameworks. So for example, I mentioned frailty is a powerful predictor. You can use any number of frailty indices or frailty scores. And time again, regardless of the tool you use, you often find that there's a really strong correlation with the more frail an individual is, the more they spend when you look at their trajectory over the course of 1 year, 2 years, or 3 years. So this is over the course of 1 year. You define everybody by how frail they are January 1st, based on historical data. And then you look at how much money they're spending by December 31st. And this is in the Medicare population. The most frail, just by the frailty index score, are spending on average around $17,000. This is an algorithm built by one of my colleagues at the Brigham and Women's Hospital, Dae Kim. And so there was other types of data analytics that went into this, and there was an initial framework that was built from this data. And this is a framework for older populations in Medicare. And that at the time when we did this work, we had really good Medicare data. And so there were 6 clinically relevant population segments. There was some interest in then taking these segments and then actually piloting them with real frontline clinicians and health systems, because this was just a segmentation framework built using data, but not necessarily taking an actual clinical lens. And so then we, with the support of the Commonwealth Fund, we undertook a 2-year effort where we worked with a group of ACOs and also the Institute for Accountable Care to try to pilot this framework, give ACOs their own data back, and then having a feedback loop to try to sort of improve and make the segments work better for people who are actually taking care of patients live. And so it went from a research academic exercise to a much more evidence-based clinical practice environment. And so what happened is that the segments changed in important ways. One is you see more segments, and I'm going to walk you through some examples just to give you a little bit of color, but I'm not going to go into very much detail because I can spend the whole hour on that talk. But what you notice is that there's people at the top who are, for example, again, the frail older adults, and we still have people with major disabilities, but then we start getting, a tier of people with, in some ways you can think of it from very high severity as you go down this triangle, lower severity, and the box here, or the size of the shape, almost indicates number of people within that population. Now, these are very general topics, or very general segments. And so what we did as part of this effort is try to really sub-segment each one of these into smaller, more homogeneous cohorts that all, with, again, using data, displayed very similar patterns of spending, very similar patterns of care trajectory across the health system, and had very similar patterns of specific types of wasteful spending. And so just to walk you through, and some of these again are still very granular, but just to walk you through, if you talk about an older population with frailty, there's different types of people with frailty. There's, for example, there's a person who has functional limitations. They have trouble doing activities of daily living. And then they could also have cognitive impairment, dementia, for example. And on top of that, they could also have a very high severity of complex morbidity. So they have multiple chronic conditions like heart failure, chronic kidney disease, diabetes. You could also have a frail older adult who only has cognitive dementia, like cognitive impairment, dementia, but is relatively otherwise potentially able to do many physical activities. Or you can have the other kind of older person with frailty who has only functional limitations and is completely, has the capacity to be able to make decisions and participate in life, and not necessarily, again, not have like dementia. And each one of these, based on the data, look very different when you follow them over the course of a year to 2 years to 3 years. Now, there's other examples of people with major disability. Disability is a very broad term. There's different reasons why someone might become disabled. We have people, for example, that could have rare genetic disorders that unfortunately since childhood, since birth, have had issues and age or get into Medicare because of disability. There's people with severe neurological disorders, and there's other functionally impairing type disorders. And then on the side of the serious mental illness, there's people with serious mental illness that may or may not have behavioral health disease. There's people with serious mental illness and behavioral health disease that may have a lot of chronic conditions, whereas there's some that might not have that many chronic conditions. And again, people, depending on the type of subpopulation they are, look different when you follow them over the course of the year. And that's very important information to know. So let's walk you through some quick examples of what the data can look like. So if we start with the first segment, the frail older adults or people with frailty, all I say is I use an algorithm that detects like whether they're frail or not, and I categorize some people as frail based on that algorithm. So if you fall within the top quartile or quintile in this case of frailty, and I don't tell you anything else about that person. All I said is that there was an algorithm that said they were frail. 1 in 4 of those individuals, if you follow them for a year, will be among the top 10% most expensive people in the Medicare population. I didn't tell you anything about whether they have diabetes, whether they have heart failure or anything, but 1 in 4 will be high cost. And then again, just because frailty is such a powerful predictor of future spend, future need. Now, if we were to subsegment this population into 2 types, the ones that have functional limitations only versus the ones that have functional limitations and cognitive limitations, in this case also have dementia or a related type of dementia, Alzheimer's or a related type of dementia. About 1 in 3 of this population has evidence of cognitive limitations or dementia. And again, this is a Medicare population, older adults, highly prevalent in that population. So if you were to do this in a general population, that might be much smaller. And if just by adding the cognitive limitation, we see that 40% of that population will be in the top 10% most expensive a year from today. And 65% of that population will be in the top 10% most expensive a year from today. And you can go further. And so the ability of the subsegmentations is that obviously there's a lot of heterogeneity within this group, and including people that have complex multimorbidity. And if you add that extra layer on top of this population, then your prediction gets up to 82%. So just by doing, in this case, 1, 2, 3 simple steps, based on, again, a lot of data that we've done over years and working with organizations, you can get your prediction to be almost 8 in 10 of the people you can target will be in the most expensive category. So this, again, is in some ways, a very simple framework to approach groups of people within your health system, within your organization, within your health plan. I'll give you another example. These are people with serious mental illness. Again, the idea is that serious mental illness is a dominant characteristic that really truly shapes the life cycle of someone's, of a person. And that's why it comes front and center. And that's, you start off with dominant phenotype, a dominant characteristic, and then you work your way in subsegment. So there's different types of people with serious mental illness. There's people that have serious mental illness, also have behavioral substance abuse issues, and then could have also complex multimorbidity. In some ways, this group is the highest risk individual within this cohort. And then you can have a moderate group. Maybe you take away the substance abuse, for example, or you can have someone who just has serious mental illness and has minor morbidity. So then maybe has hypertension and hyperlipidemia, but does not have heart failure, chronic kidney disease, and diabetes, for example. Now, when you look at these patients, they again look very different. I'll just give you some quick examples of how much money over the course of the year these people spend. The most complex, a person with serious mental illness spends about $45,000 a year. And again, we define them at the beginning and then track them over the years. So they're all already in this segment. It's not that they developed a certain condition throughout it. And then you can see that there's, lower levels of spending, not surprisingly, as the complexity of the individual goes lower. The next step, though, for this is, so it's one thing just to know that they're going to be expensive, but this doesn't necessarily help you figure out what you should be doing for these people. And so then what you do is you have to take these costs and then start breaking them down further. You have to be able to have the ability to figure out what proportion of the spending is in the inpatient setting, what proportion of that spending is in the post-acute care setting, what proportion of that spending is potentially wasteful, as defined by many different algorithms that are out there, low value care being one of them, for example. And another one, it could be what type of spending. So is it related to mental illness treatment, or is it related to chronic conditions treatment? And in this case, it's relevant for this segment. And so if you were to just ask what proportion is related to treating the serious mental illness, meaning the primary diagnosis of the visits were because of the mental illness, only 5% of this amount is related to that. And 95% is related to chronic medical conditions. And this presence of serious mental illness increases spending on chronic medical conditions by 37% more relative to people who looked identical and only have, but don't have serious mental illness. And so there's more examples that you can do. You can look at a different segment and understand why specific patients are high cost. This is another example. We again go with a frail older subpopulation and a person with complex multimorbidity. One segment that was important was individuals with HIV/AIDS, which are growing in the Medicare population, who also happen to have complex multimorbidity. These two people are high cost. And they're really, but again, this does not necessarily help you determine what you need to do about them. But if you go further, break down their costs, you can understand that 70% of this 45,000 in this subpopulation is only related on hospitalizations and subsequent post-acute care use. Most of the majority of that spending is on these two. And if you were to further break this down, is often due to potentially avoidable conditions. If you look at this population, though, with HIV/AIDS and complex multimorbidity, you might think that they might also have a lot of hospitalizations, post-acute care, but in reality, it's all due to drugs. 68% of this is related to drugs, mostly related to antiretroviral drugs. And if you look at of the people who are on treatment, they actually look identical to those without HIV. And so then, this population, you wouldn't necessarily want to target a lot of your efforts trying to reduce hospitalization and post-acute care, because that's not where the money is. And so the other thing in the last minute, I'll say that the other things you can use your framework is to try to understand which programs work for specific patients. This is an example. We're using national Medicare data here. And you can imagine one program at a national level is ACOs. Medicare ACOs, we did a quasi-randomized difference in different study, tracked people over 8 years, and found that ACOs are associated with 2 to 3% net savings on overall older adults with frailty. You could have flipped this and said, if within your health system, what patients are in care intervention number 1, and find a group of patients and then follow them over time and then identify. And Lewis will talk about what Tufts or Point 32 is doing to help this at a plan level. And so again, it helps assess return of investment. And the last thing I'll say is spending very spending very substantially across people and organizations. If you were to plot out spending across older people with frailty, there's a big distribution. There's people that are spending over 100,000, and there's people that are not spending a lot of money. And you can actually attribute these patient populations to specific providers and figure out what, if on average, certain providers are spending more for the same type of person versus spending less. And this can help you target certain provider practices and figure out why some are performing better than others. And then the final thing that Andrew will talk about is that I have not mentioned anything about social determinants because we had Medicare data, but it is critical, absolutely critical to try to include information on social determinants, because it will improve all of your modeling and all of your predictions much better. And you'll hear a conversation about that as well later today. So thank you so much for your time. Just as anybody is interested in that segmentation framework, it is available for download through the Playbook website. It is there. The code is there. And also there is information to be able to understand how to run the code as well. Thank you so much for your time.
Great, thank you so much, Dr. Figueroa. Wonderful presentation. So as Dr. Figueroa mentioned, if you would like to see the segmentation framework, it is posted and available through a downloadable code that can be used to identify specific and actionable patient cohorts with complex needs. And we'll be sharing that periodically in the chat for you. So now I'd like to turn it over to Luis Cabanilla from Point 32 Health.
All right, hello everybody. I'm off to a slow start already. I am Luis Cabanilla. I'll make one point real quickly. Jose had mentioned Tufts Health Plan. So Point 32 is a recent combination between Harvard Pilgrim Healthcare and Tufts Health Plan, which are two nonprofit groups in the health plans in the Northeast. So it's one of the largest health plans now in the Northeast segments. So we geographically and ideologically are very close to Jose. So we worked with him starting 2 years ago to kind of start defining a way to understand our population. So being a larger health plan, we cut across commercial, we cut across public plans for Medicaid and connectors plans, and then senior products as well for dual eligibles and HMO type products. So we have members who are newborns all the way up to 100 years of age. So we have a very diverse population in every possible way. So their stage in life, their socioeconomic background, and everything in between, and health needs. So part of the need that we had as an organization, and it's only been exacerbated by the combination, is to have a way to understand the population and kind of make clinical and strategic decisions based on that. So when we started working with Jose, we created the 7 segments and 25 subsegments, which look very familiar to what you just saw in the previous presentation. And it's kind of walked through that. But in addition to the segments, we also created what we call a clinical complexity score, which is a little bit different from a predictive model. I saw a Q&A question about a predictive model. I'll talk about that a little bit in here as well. But the goal of the complexity score is to kind of have a disaggregated model where you have a composite index that shows the complexity of need for a member that cuts across their utilization. So if they're going to the ED a lot, they have unscheduled admits if it's a behavioral health need or if it's a SUD need, and then it incorporates social determinants of health. Distinct from a predictive model, but I talked about that as well. And then one point I just wanted to make, for a lot of what we go through, there's different ways and different levels that you can do this at, but this was a 0 to 60 approach for the company. So there's quite a bit of effort from the clinical teams, the IT teams, and the work that we did with some consulting support from Jose and from an external group called Clear Intelligence. So with the segmentation, a lot of what we had done previous to the work that was done for this project was to look at kind of a disease registry where somebody would say, like, all right, we'll have a list of everybody who has diabetes, we'll have a list of everybody who has depression, and you kind of try to craft a strategy that way, which can be very tricky because there's a lot of overlap between the two, as was mentioned in the previous presentation. And the characteristics of a disease aren't as heterogeneous as you tend to think. So the goal was to distill as much information down into a small number of data points as possible so they could be used by clinical teams to make kind of informed decisions, and by strategic teams, and by anybody in the company to have a common set of data that they can get as much insight in a little data point as possible. So really reducing the amount of data fatigue and the ability to be kind of nimble to adjust to the changing characteristics of the population. And that fits into a larger strategy, which I have a bullet on at the end, to kind of be able to do continuous improvement, where you can understand the population, you can decide what you're going to do about it, and then you can measure the impact of that, and then that leads back to the start again. So you can really use your resources in the most effective way to impact your members in the most positive way possible. So if you look at this segmentation, almost all of this will look very similar to what Jose had presented previously, so I won't spend too much time here. There's a couple of things I will point out. based on the characteristics of our population, we're 0 to 100 for member age. So there's subsegments that we created that are based on age. So there's children and then there's adults. The SPMI is very similar to what was mentioned before. And the way we kind of bucketed it, there's also buckets down here for healthy members and members who have limited information. And I'll talk to that a little bit later, but if you're a health plan and you have assigned members, there's a lot of people who just don't use healthcare at all. So you don't know anything about them. And it's from our perspective and from our experience, it's been difficult to say that those members are necessarily healthy. They're just potentially underutilizing healthcare that they should be using. So that's an important characteristic that you can also characterize members based on what they're not doing, just in the same way that you can characterize somebody based on what they are doing. So in previous iterations before we started doing this work, a lot of times you would run a program and you'd say like, all right, we want to do a care management program that's based on the, you need a criteria for that. So you say, we'll work with a diabetic member and we're going to look at that most expensive member first, and that'll be the person that we have the greatest potential to impact. And so if you follow that process, you can see that you can end up with a member who might be in a chronic, complex chronic, all the way up to, so you can have very different members and very different profiles. So we'll talk about that a little bit as well. And then the overview of the stratification, there's a question about predictive modeling here. So internally, what we've done is we have a 10-point scale that's based on utilization for total paid claims, ED and inpatient, and then based on chronic condition burden and social determinants of health. This is a platform that we found has been beneficial, that if you were trying to predict what's going to happen to a member, you can incorporate like a suite of models instead of a single point estimate. So if you're just saying what's the risk of hospitalization, risk of hospitalization can mean very different things. If you're looking at a member who's undergoing chemotherapy, if you're looking at a member who has ESRD, or if you're looking at a member who's younger, relatively healthy, but has an SUD consideration. So being able to have like a kind of profile that gives more than just a single point estimate has been very beneficial for our company and for the work that goes on. And then it allows clinical teams and strategy to kind of focus on different aspects. So beyond the risk of a member, you want to know what the risk is of something that you might be able to do something about. So this has worked well for us. And it's very stable, very basic kind of platform that gives out a lot of data points and gives a lot of clarity to what you need to understand about a member, so you can start to think about that population. So within that last bucket, we have the SDOH, and as Jose had mentioned, it's a super important area. It's an area that we're still evolving in. It's something that we're still working towards. But what we've done is we've kind of tried to boil it down to 3 data points. And those 3 data points are aggregation of claims-based Z codes, self-reported data, or data that's collected by care managers or provided by the state in certain situations. And those would be 3 areas that might impact your ability to utilize healthcare. So if you look at that, there'd be housing and economic instability that would have a large variation within that. So you could have a member who's experiencing homelessness, or you could have a member that's moved a lot and has some housing instability. So it's not a very consistent definition, but it gives like a good starting point to understand issues that might be going on beyond the traditional claims medical profile. The second is member and provider communication. So this would record anything that considers a Frail or DEI consideration. If a member is not a native English speaker, understanding the instructions from their doctor, understanding prescription medications, or cultural differences, and how they interact with healthcare could be a very important consideration. And beyond that, it could have very negative impacts and how likely somebody would be to suffer a negative outcome as a result. The last is access limitation, which would be anything that would physically impede your ability to get in to see a doctor. Telehealth, with the changes that have happened, provides like a new kind of interesting area for research in this area, but it includes areas where somebody has a physical limitation, like the blindness or something like that, but then also like a single parent who might not be able to get away from their family to make it into a doctor's office. So the goal of this wasn't as much of a statistical analysis to look at something as much as a way to distill a bunch of different data points from a bunch of different sources into a few very basic bullet points to provide for a starting point to understand the population. As I mentioned before, so what we do is a little bit more of a member profile versus the predictive model. So So the examples that I've seen in some other companies would be like, this is the member that's most high risk for readmission or an ED, but you really need to have a little bit more information around that to understand the member. So the segmentation stratification provides a lot of ability to channel the member to the right group or the right program within a suite of interventions to understand what should be done and help the member as best as possible, the most effective way possible. So having said all that, I'm going to skip ahead. This is our first example. So this is fake data here, so don't look for anything on this, but we have found that the data that we have across our membership is generally very concise and very similar to what you would see in the larger national trends. And a lot of that reflects that our population is large enough and it mirrors the general population enough to show some similarities. So in this is a Tableau dashboard that we've created that kind of helps to understand the population. So if you focus on the left here, you see our population. Obviously, the members that are limited data and healthy members won't be included because we've limited it to a population of members that have type 2 diabetes. So within that population, you don't just have a member with diabetes and you can't just treat the diabetes. So to focus on a very member-centric approach, you can look at a single chronic condition and kind of see like how many different potential interventions there are. So if we were to look at this, you have an advancing illness. So you have members that have active oncology, or they might have end-stage renal disease or something like that. And so the diabetes isn't the primary driver, or isn't the primary cause of the disease burden for the member. So that type of intervention would be very different than somebody who's in a chronic state, who probably only has a very early onset of diabetes and would be more appropriate for a lighter touch intervention. So if you're looking at the groups here, the way it's been operationalized is that the intensity of the program will increase with the intensity of the disease burden for the member. When you do this, it kind of affords you the ability to look at the population, not just at the disease level, but also more of a profile where you can get away from the idea of looking at a single chronic condition and get away from the complexity of saying like, all right, we want to look at 10 things, and then like it becomes much more complicated, and kind of look at the profile as Jose said. It's much easier to look at a complex chronic member and say, all right, I can look at this. How many members are within that population? What does their ED and inpatient utilization look like? What does their RX adherence look like? And is there an opportunity for us to do something in that population that'll be meaningful for the plan as a whole and for the membership as a whole? The second example here, this is a little bit different way, but when you kind of create these profiles, you can do a lot of different applications. So this is, again, sample data. It's not real to be looked at, but it's what we've seen has been indicative of what we've seen over the last year. So if you take a snapshot, and the way we kind of do this, we have a snapshot of our population across time. When you do that, you can see how members move between segments across time. So in the example here, if you have members with limited data, who I mentioned earlier on, you have members that have an extended period of time where they have no claims. They join the company, or they join the health plan, they have a longer period of no claims, and then you can see over a period of 2 years, like where those members have gone once they leave that. So once they start to accrue claims, and once there's more known about the medical disease burden of the members, you can understand. You can see that there's a certain number of people who have severe illness that probably had to immediately go to a very high level of care. And then you have a significant number of people who actually have complex chronic conditions. And the largest group are members who are generally healthy. And so it would make sense that they have low utilization. And then you have members who continue to be non-utilizers. So if you look at this, you can infer, like within a population that's not utilizing, that there's still members that have a high disease burden. So they're members that are definitely not healthy. And then you have a potential to decide if that's an area of interest for a program, or if that's something that you want to focus on to try and improve your membership. Another area that we kind of track the complex chronic is an area we're interested in. Just anecdotally, not based on this data, but you can see behavioral health needs have increased. So SPMI subsegments have increased in size across time, and so you can understand the needs of the population and how you might be able to better address the needs of the program by reflecting the changing need of the population as a whole. And then one last one, as we give an example for, is so the COVID vaccination. So obviously, COVID started last year. the infrastructure set up for this program. So it was fairly easy though to use the data a little bit more on a basic level. So as the research started for COVID, it kind of came out that the number of chronic conditions that a member has and the age of the member are the two greatest predictors for very negative outcome for COVID. So within that, the dashboard here on the right is what was set up. This tracks, again, a sample population, but based on vaccination rates within those populations, but then also you can see the members on the right are the highest risk members. So you could start with outreach for the highest risk members and then move your way back to lower risk members. And using just the basic demographics that we also collect for the members, you can look at information by zip code and things like that to kind of get a sense of where there's areas of need or where there's opportunity to prioritize outreach efforts for membership. So the last slide I'm just going to cover real quickly is, so like when we're doing our programs, we're also working towards kind of creating a way to measure the impact. So here we have a basic analysis, and it's another area that we're working on evolving and kind of improving our data science capabilities internally to create like a outcomes analysis to say, like, what do we really do for this population? Do we impact the ED? Do we impact how much preventative care they're getting, which is important, how much their unscheduled and DH utilization is, and you can choose any metric, and a lot of the metrics are kind of defined on the intent of the program, but it allows you to kind of understand where you're spending resources in a very efficient manner, or where you have an opportunity to maybe shift resources or make an adjustment to the program to improve how those resources are being allocated. So I think it's just about on time. I may have gone a few minutes over, but I will turn it back over. So thank you.
Thank you so much, Louis. Great presentation. I just want to encourage everyone that if you have questions, please put them in the Q&A. The team is monitoring that Q&A, and at the end, as we said, we'll be having a discussion. So now I'd like to turn it over to Dr. Andrew Renda from Humana.
All right, thank you very much. So I'm Andrew Renda. I'm the Vice President of Population Health Strategy at Humana, and I lead our bold goal team efforts, which really focus in on social determinants of health. So you heard both Jose and Louis talk a little bit about social determinants of health. I'm going to go into some more depth about how we're thinking about that data ecosystem and the taxonomy and advanced analytics and how that impacts our overall population health strategy. First off, though, I wanted to kind of just take a step back and take more of a global perspective on this. I think to do population health well as a country, we need to invest appropriately. And right now, this is probably not news to most folks on this webinar, but we spend 20% of our gross domestic product every year on healthcare. So what you can see on the left-hand side of this slide is that 88% of it goes to medical services and very little goes to anything else. Whereas if you look on the right-hand side, you've probably seen versions of this, but this is what actually makes up our health. You've got healthcare is actually 20%. So there's a mismatch in terms of our investment. We're spending 88%, it really only accounts for about 20% of our health. And what really makes up the bulk of our health are the health behaviors, 30%, and the socioeconomic factors. So to me, that's why we really need to sort of flip the script a little bit and figure out how to invest smarter in health for the populations that we serve, that we have accountability to. And so to that end, we need to focus on these socioeconomic factors, but definitions and terminology, as you've heard in the past two presenters, are really key, because sometimes it can get confusing if we're not sure exactly what we're talking about or how we're defining it. So we at Humana use these definitions. This is borrowed from a National Academy of Sciences report, as well as some other publications. But to really parse out and build a taxonomy around the idea of structural determinants of health, which are kind of social and political sort of context of where people live, differentiate that from social determinants of health, which are these upstream influencers of poor health, living conditions, food availability, healthcare system, things like that. And then further differentiating that with health-related social needs. Social needs are more of the immediate health-related needs that individuals have. So things like food insecurity, loneliness, transportation, housing quality, housing instability, and different things like that. And a big piece of our work really focuses in very intentionally on health-related social needs. We use that term that was coined by CMMI and their Accountable Health Communities work. And so like that, you know, each word in that term is really important. Health-related is really important because previous to Chronic Care Act and some other things that happened around 2017, 2018, social needs, social determinants were actually not considered to be related to health and health outcomes. And so that had implications for coverage on insurance products as well as, you know, other things. And so to call these things out as health-related and identify them as individual social needs is really, really important to really kind of everything else that we're doing. And so that leads us to Humana's bold goal. Our bold goal is to improve the health of people and communities we serve because we make it easier for people to achieve their best health. I'll talk a little bit about kind of what that is. We have a national strategy. We have a very localized strategy in specific places. But ultimately, we want to improve health-related quality of life, and we do that primarily by addressing root cause upstream influencers like health-related social needs. And so you can see our footprint here. This is kind of where we are in sort of 17 or 18 geographic communities where we do this work specifically. And you can see some of the partners that we work with before. As we align our strategy around specific social needs like food insecurity, we align with partners like Feeding America, Meals on Wheels, No Kid Hungry, Mom's Meals, et cetera. We also have a very intentional focus on loneliness. So we created a Far From Alone campaign. You know, we work with organizations on that regard. And then along the lines of data and interoperability and terminology and codes, we work with the Siren Network, and I'm on the steering committee for the Gravity Project, which is really work to define more granular Z codes, because Z codes are helpful now, but they're not specific or granular enough. And so there's an effort to kind of create further granularity in that. So a little bit about our strategy. So it starts fundamentally with data and analytics. That then leads to research and insights. And so we really, again, have to define our terms, figure out what we're talking about, and create these insights that show who has gaps and how the gaps are influencing health and health outcomes. Then we can start to get to some of this other work where we're going to screen our members using validated screening instruments. We're going to integrate with provider platforms. We're going to test and learn, have an innovation pipeline where we're going to test new solutions and figure out what does move the needle in terms of stabilizing chronic conditions, addressing clinical gaps, and ultimately reducing healthcare resource utilization and saving costs. And so as we figure out kind of what solutions are most effective for which populations, then it becomes an issue of how do we best scale and sustain this kind of work. And scale can be done organically from a pilot to a program. It can be done through integration into other work streams that we have. We have own clinics in our primary care organization where we can integrate there. We have value-based payment relationships with providers where we can integrate social needs there. We can integrate social needs and addressing them through our clinical operating models, be that telephonic or in-home or elsewhere. So there's a variety of ways that we can scale the work, but it really starts with fundamentally with understanding what the problem is, testing solutions, and then figuring out the right path to scale for things that are successful. So I wanted to spend a minute and just get deeper into the data because we've been really intentional with creating a social determinant data ecosystem. We at Humana, a 60-year-old company, we're very sophisticated when it comes to clinical data, looking at claims and labs and EHR kinds of things. But social determinants has largely been kind of a white space. And so we've had to create something from scratch, understanding how we acquire data, how we standardize and certify it, get it into an ecosystem, and then perform advanced analytics and products from there. So we have internally at Humana a data governance office, which has helped with this process. So as we're screening our members, as we're capturing data from providers, as we are bringing in external data sets, geospatial data sets from CDC and Robert Wood Johnson and other places, we have to have a way of standardizing, again, the terms, mapping the data sets to specific social needs domains, so we have common definitions, and certifying those data sets to the level where we all kind of know what we're talking about. Then we can combine it into a larger longitudinal health record that combines clinical and social data. It also allows us to use those data sets for advanced analytics, things like predictive models. We've created a social risk index and things like that. And then on top of that, you can create data products where you can have reporting mechanisms and other tools and stuff that you can use. This is really helpful sort of on the front end, identifying where needs are or prospectively identifying where risks may exist. And then all of this sort of data and analytics ecosystem is really helpful on the back end to measure the impact of interventions that you're doing. So super helpful kind of throughout the process, but I think it's important that we've been really intentional with defining our terms and mapping these data sets and really standardizing the process of how we do it. This is an example of some insights that have come from some of this work. So this represents a sample of 100,000 of our Medicare Advantage members and 30,000 of our Medicaid members, where we used a validated screening instrument, comprehensive screener from the Accountable Health Community's work, and screened across about 15 different social needs domains. And so what you see here is the prevalence in populations that Humana serves. So the green boxes are Medicare. And so what you can see is that 41% of our Medicare Advantage members have a financial strain. 29% are lonely, 26% are food insecure, and it kind of goes on down the list from there. Prevalence is even higher by every domain when you look at Medicaid population. So this was informative because suddenly you can't deny that these issues exist in the populations that we serve, and they are rate limiting factors in people achieving good health outcomes. So it's something that we certainly need to address. Now, we do need to corroborate that with other data points. And that's why I think this is really important to show here, because when you look at those 5 priority social need domains on the left, then you say, okay, let's look at the prevalence within our populations. And so you can see that prevalence there from the previous slide. Then we looked at what is the impact of these things on health-related quality of life, which we measure using CDC's Healthy Days tool. And so again, you can see there, loneliness has the biggest impact, food insecurity is second, housing quality is third, and so on. Then we looked at the association between people who have these specific social needs and the association with higher PMPM costs. And so again, you can see that ranges from roughly 25% higher to north of 50% higher costs when you look at people who have these specific domains. And it's an exponential increase when you actually combine some of these social needs. So we take all of those kind of data points and then we corroborate that with external research. So we do literature reviews and say, gosh, well, we see that, people who are lonely have a much higher likelihood of premature death or of developing dementia and so forth. People who are food insecure are more likely to have diabetes, develop diabetes, or progress in their condition. People who miss, who don't have transportation miss medical appointments and they have worse health outcomes. And so that's an example of how we standardize the data, that we look at it in a sort of a number of different domains, and then we can tie it in with clinical data and wellness data and other data sources and really paint a really solid picture of why these things are important and the kind of impact that they have. And this is a tool that we put together called Population Health One that really combines all of those things. So it's interesting because we pull in all these data sets, and then now we can do hot spotting. We can look at high risk members. We can do kind of heat mapping, sort of visualization types of things. We can do queries. We've incorporated predictive models for individual social need domains like food insecurity and transportation housing, also our social risk index. So a really kind of interesting comprehensive tool that we developed through a relationship with Microsoft and the Power BI platform. So that's pretty cool. And then just to talk a minute about solutions. So, none of this really matters unless we're creating solutions that have an impact on people. And so this is sort of a timeline over the last few years of how we've looked at specifically at food insecurity. So it started off with some of that formative research, relationships and partnerships with organizations like Feeding America. We looked at, creating some of these predictive models and looking at the data analytics around how we screen and understand and identify people with food insecurity. We tested and learned with new solutions. We have looked at creating quality measures for social needs, the way we would have quality measures for chronic conditions. So we've worked with the National Quality Forum to create quality measures for food insecurity. And then you fast forward to in the last year or two, we've really tried to bring this to fruition and really kind of have interventions that have impact on people. One example of that is a healthy food card, which is a value-based insurance design or VBID benefit on many of our Medicare Advantage plans. And that's patterned off of SNAP and WIC type benefits where you get a certain amount of money to spend on groceries every month. But we put this on, on many of our plans and have access to it, especially dual eligible members. And we've seen really positive early results from there. We've also launched our first of its kind, I believe, a social determinant value-based payment innovation pilot, where we're incentivizing primary care doctors to screen social needs, to document them, and to make a referral to a community-based organization. And so you can just see sort of how we built upon first data, then insights, then innovation, and now we're kind of looking at how to scale some of these interventions so they can have a bigger, more sustainable impact on individuals. We also have a lot of thought leadership. I won't go through some of this now, but we do issue briefs, you know, on key topics, social determinants, data related, health equity, various things like that, that we publish as sort of a survey of what's happening and political issues and policies around that. And if anyone is interested, you can go to our website, humana.com/population health, which has all of those issue briefs, along with member resources, patient resources, and provider resources as well. But I think I'll stop there and we'll move into Q&A. So thank you all very much.
Thank you so much, Dr. Renda. Okay, so now we'd like to have a discussion and answer some of your questions. Again, if you have a question, please submit it at the bottom of your screen where you see the Q&A icon. And I'd like to start with a question that someone asked. And that is, and I think any of you could answer this, although maybe this is for Jose. How can an ACO with several payer partners with a range of contracting requirements take the initial steps towards a model like this, building up the infrastructure as they go? Where do they start and how can they get paid to do it? So Jose, I'm wondering if you want to take a stab at that one.
Yeah, although I'm sure health plans who engage in alternative quality contracts, ACOs might have a better answer as well. But that's a great question. And I think someone on the Q&A, Priscilla Wing, just mentioned that, you know, you could imagine that everybody can be doing their own segmentation frameworks, and, you know, you can have one group doing on this side, another group doing it over there. How do you think about sort of maybe having in some ways, a universal segmentation framework for different purposes, but supported by the same infrastructure that might inform, you know, your strategy for particular subpopulations with payer 1, payer 2, and payer 3? Unfortunately, we're not there yet. You know, it is really hard to think about how to do that. But but from at least if I can answer from the Medicare perspective, every ACO gets their own data, and there's interest in trying to somehow figure out how we can start having really good learning networks across different ACOs and looking at applying the same type of segmentation framework across different ACOs. And there's organizations out there that are currently trying to do this. NACOS is one, the Institute for Accountable Care is another one. They actually have a lot of resources to segment your populations for you. They have that ability. And so that's one way. If you don't have the internal infrastructure today, there are organizations out there that already have your individual ACO data, which is available, that they actually get it from CMS themselves. And you can think about partnering with some of those organizations that have the infrastructure and ability to sort of take, you know, give you insights about your own data. The payment model, I think that is, a very interesting conversation that, you know, theoretically, the fact that it's prospective payments to do population-based care should free up some dollars within your health system to be able to invest in your own data infrastructure. It doesn't always happen, but that's the whole point of moving towards accountable care. And I wonder whether Andrew and Lewis can speak about, you know, how they think about that from their side.
For my part, I think like the biggest thing that we're kind of focused on or interested in is simplifying healthcare, to making things less complicated and less convoluted. So to the extent that things are done that way, it's great. When we did our work internally, like a lot of it was just around using the infrastructure that was in place and then supplementing it with expertise from outside groups. So it's more complicated than just having an internal team do something on the side of the desk, but I think it's worth the investment. And it's also a great area for showing value for everybody.
The only thing that I would add to that is that globally speaking, I feel like we generally have to get away from thinking in silos when we're talking about segmentation and prioritization. And I'm guilty of it as much as anyone else is. But I think, when you think holistically about health, about whole person health, you're talking about a biopsychosocial model, right? There's physical health, mental health, and social health. And I feel like what we need to aspire to is any kind of segmentation and prioritization needs to include all three of those. And there's a lot of fundamentals that come before that. You have to standardize the data. You have to figure out how to combine it. You have to figure out how to prioritize when somebody has a complex clinical issue. They also have a behavioral health issue, and maybe they have social needs as well. How do you figure out what's the next best action for that person? But I think that's kind of where we have to get to. And I think the playbook model and the segmentation there is a great step in that right direction, thinking about, what is it to be multi-morbid, clinically complex, to have disabilities, SMI. But again, beyond that, I would look at a whole person health model where it looks at people that are complex across all three of those different domains, and figures out a way to prioritize the next best action for an individual.
Great, thank you. I'm going to skip to a question from Priscilla Wang. Hi, Priscilla. Her question is, it seems that one major challenge is that provider systems and payer organizations are performing segmentation in parallel and perhaps targeting the same patient or member in a different non-complementary way. For high-risk patients, particularly those with serious mental illness, multiple outreaches may confuse them and decrease their likelihood of responding. Do you have suggestions for how provider systems and payers can better integrate efforts in both identification and targeting of these populations? So I'll open that up to anyone.
Well, I don't mind starting. I keep harping on common definitions of things, but I feel like it's sort of an issue of interoperability. If we can agree to terms and codes and definitions and that sort of thing, then we all know what we're talking about. And then I think beyond that, it's coordination of care between all the various stakeholders in an ecosystem that is caring for an individual. So you may have a primary care doctor, a specialist, you may have emergent care that happens and, things like that. And then you have a payer involved. And so there needs to be a coordination of who's providing what service and a connection as the service is provided that, there's an information going to the other stakeholders as well. So when they see that patient, they have all the relevant information and know what's been done before so they can make an informed decision about what to do next.
I'll just add one thing, so the prioritization of, so if you have a utilization management program or care management program, or if the primary care doctor has program, the checklist for what they go through when they're trying to impact a member, or trying to help a member, one of the core aspects of that needs to be coordination of resources between all the groups. So I think one of the major failings, and it's definitely better on the ACO side from what I've seen internally than groups that aren't part of the ACO, but to know what resources are available from a payer would be a core competency for somebody on the provider side, and vice versa, just to make sure that the areas, even areas where you're doing duplicative work, but you're also missing an opportunity if somebody has a resource available to them that they're not aware of.
Great, thank you. And I'll just briefly say that we actually did some work in Massachusetts where we worked with the Medicaid ACOs, and some of the things that you're saying were key core findings, understanding resources that the payer has available for the provider, and also building relationships, not underestimating building relationships between the payers and the providers and the teams so that efforts were not duplicated. So thank you. I want to go to a question here that is, I think, for Andrew. How long did it take to build your own SDOH dashboard, and what kind of resources did that kind of project require?
Yeah, that's a great question. I guess it depends on how far back I want to go. It was probably 3 years ago when we first started the process of standardizing and certifying these data sets, sort of defining our terms and doing the mapping exercise. That was all fundamental. And then over the last, I would say 6 months to a year, we actually built that Population Health One tool. And it was a collaborative effort. Internally, we have a digital health and analytics organization where you have the data scientists that are expert in that kind of thing. We have an IT sort of technical organization that helps with that. We had a vendor involved at one point, and we had the subject matter experts from my team. So it was kind of it took a village to build that tool, and it took financial resources, it took commitment from leadership. And it was definitely a process over time, but it was, a year or two to sort of build the data infrastructure that then allowed us to build, both the advanced analytics and the data products on top of it.
Thank you. I'm going to jump to a question here that I think is related. This question says, regarding social determinants of health at the patient member level data, many vendors have started selling this data. Thoughts on collecting this data yourself, patient reported, versus just having the ecological neighborhood data versus purchasing this data via vendors?
Well, I want it all. I'm greedy when it comes to data. So, I'll just call that out. But what I will say is, to me, a gold standard is where you've screened a patient directly and asked them the question, are you food insecure or not? And you get the answer from them. Absent that, we look at other types of data to inform us on what issues people may have. And what we've had to do, again, as part of creating our data ecosystem, is we put together a taxonomy. It has 3 levels. And the first level is known data. And known data is based on a validated screening instrument or documentation of a Z code. And if we don't have that, then we look at derived data. And that's our advanced analytics, predictive model, social risk index, where you can figure out there's some propensity that an individual has a certain issue. And if we can't do that, we don't have enough data for that, then we look down at inferred data. And that's what you're talking about with kind of the external geospatial data sets that we may get from either purchase data, a Marilink, KBM kind of stuff, or census data, or larger data sets from CDC and Robert Wood Johnson. So to me, it's kind of a taxonomy, and there's a gold standard, and then we kind of go down the levels until we get enough information that we can make a decision or take an action.
I just want to echo one thing. So I agree with that. And the prioritization of the data is super important. Geography can also be important. So Massachusetts, there's much more condensed socioeconomic differences within a very small area. So it's a little bit more difficult to use SBI or something like that within that context. So it makes it, depending on your geography and what the areas that you serve, it can make a little bit of a difference there. And one area that we also have included for social determinants of health is we kind of track RX non-adherence. So if somebody has a continued pattern of RX non-adherence, it's an indication of health literacy. And so there's tricks that you can use within even just the claims data without having a stated comment that can help you understand some of the challenges that a member faces.
I just want to I think at the end of the day, though, you should try to get individual level data, because social vulnerability is dynamic. And so, for example, in some of our data during the pandemic, we track the newly unemployed, and that population, the newly unemployed, became, a lot of them lost insurance, a lot of them reported new food insecurity, new housing insecurity, and all of that was tracked with poor measures of health and well-being. And if you survey someone, or if you are basing everything on historical data, the world changes and people's lives change with it. And so if at the end of the day, individual data is very helpful. And then not only once, and Andrew can speak to this, they survey their data, their members multiple times over time. And that adds valuable information, because changes in social vulnerability you see them in the data. There's changes in health-related utilization.
Thank you. I want to circle back to a question that was asked earlier related to race, ethnicity, and language. So the question is, has there been an analysis of the impact of race, ethnicity, and language on any other demographic information, on effective segmentation and or pop health management? So anyone can answer that one.
The answer is yes. There's a lot of information on this, but it is a complicated answer, and that's because when we start thinking about differences in utilization and need by race and ethnicity, and the use of predictive analytics and the use of algorithms to figure out who is high need gets very tricky. For example, there was a Ziad Overmeyer study in I think it was Amy Finkelstein as well, that put out a paper that, one very common used algorithm to figure out who should get some sort of social intervention was essentially assigning fewer Black people into that intervention, because historically they had lower levels of access. And if you base any algorithm on historical utilization, and if you don't take into account access being issue, meaning like there's barriers to getting care, then it can essentially have potentially negative consequences in some of your algorithms or in some of your intervention or how you assign interventions. But it is certainly and I'll let Andrew and Lewis comment further if they've used it for their work.
Yeah, I mean, I think that we're doing a lot of data disaggregation currently on race and ethnicity. And what you see is that there are significant differences and disparities really across a whole host of metrics in terms of prevalence of chronic condition, adherence and compliance with chronic conditions. We look specifically at avoidable hospitalizations, and we see differences there. And we see differences among the prevalence of individual social need domains. There are really significant differences. And to Jose's other point, we are going back and reevaluating all of our predictive models and other, advanced analytical models, because he's exactly right. I think sometimes there are groups that access care differently or have different attitudes about care. And most of our models that we build now are based on data that we have, not on data that's absent. And so if a certain group is not using certain services, that's not going to show up in that model, but the model's not taking account for that group. So we're going back and trying to retrofit some models and just seeing if there's any, sort of AI bias or anything like that. I think it's important for us to figure that out.
Just add one thing. So it can turn into kind of three-dimensional chess to understand every potential consideration when you look at a problem like this. So we've been working with Elon Peltz, which came out of that work, and from the Harvard program side prior to the combination, to kind of make sure that there aren't systematic issues for who's been identified and engaged. But there's kind of followed the whole pattern across. So it's like being aware of a member is one thing. How effective you are at engaging a member, if you're looking at a care management program, is another issue, and then how successful those members are once they follow through is another issue. And all of those can be indicative of like a failing of the program to capture all the diversity of the population. And then in the negative space as well, if you look at utilization management, if you're denying certain services more for one group than another, if there isn't like a very concrete reason for that, it can be an indication of a problem within your company that something you need to be aware of and something you just need to think about. But it's kind of been my experience, like when you think about it, you can overthink it, and then you kind of get paralyzed by the thought process. So like kind of coming up with a few like very concrete areas that you want to look at as a starting point, and that informs what you can do in the future.
Just a quick add, the other thing to think about is when anything with issues of health equity and disparities, you have to understand why you're seeing those disparities, and organizations need to get better at measuring issues of racism, both individual, systemic, and structural racism within the organization, within their workforce, because at the end of the day, it's not race that's a risk factor for poor health, it's racism that unfortunately impacts certain populations more so than others, that leads to that poor health and well-being. And unfortunately, we don't have good ways of measuring that, but there's a lot of work currently on that specific topic being led by folks at the University of Minnesota, folks at Penn, and folks here as well at Harvard School of Public Health, to try to figure out how we measure racism in our system and how do we sort of try to like dismantle that.
Thank you, Jose. That's a really wonderful note to end on. So I want to thank our speakers, really wonderful and informative presentations. And just want to, again, point our audience to some resources that are linked here. Yeah, just thank you to all the panelists. Again, I want to invite everyone to share your work with the playbook. If you or your organization has established a promising practice related to population segmentation or published a study on your complex care program, please consider sharing it with the playbook by going to the bettercareplaybook.org/submit or /submit. We also encourage you to use the playbook to search for research and implementation tools to help you as you're looking to develop strategies related to population identification and segmentation. So thank you to our presenters. Thank you to the playbook team. And just want to remind everyone that we value your feedback. And if you can complete the evaluation survey, which I think is in the chat. I'm not sure where the evaluation survey is. Maybe it's coming up right after the webinar, but please complete that if you see that. Thank you, everyone. Have a wonderful day. Take care.